started. Uh, so the plan is that we will talk about this very important topic, uh, Cardiorenal Syndrome today. So basically, this is a topic which is very important, and we are seeing more and more patients now with this particular issues. But frankly, we don't have too many options how to treat that. We know a lot about the pathophysiology, but how to make difference still there are only very few options are available now. So that's why I want to make this presentation in two portions. One portion will be a very briefly, I will take maybe 20, 25 minutes, hopefully not more than that, maybe even shorter, just to present some slides about the cardiorenal syndrome. And after that, I would like to discuss things. I mean, you have a case or you want to have a question regarding that, how to manage particular case, and what are the available options we have, we can talk about that. So that's why I'm doing. So let me start with open my slides, and I'll go a bit quickly. And this particular slide was actually made for my own fellows. So some things are not applied for our, for Pakistan, so I will skip that too. So let me just open it and go quickly. So cardiorenal syndrome. So cardiorenal syndrome basically is that when there's a cardiac issue, there's a cardiac problem that involves the renal malfunction. Basically, that's cardiorenal syndrome. So at the same time, when there's a renal failure, either acute or chronic, that can affect also the heart function, and that can cause renocardiac or cardiorenal syndrome. So when there's a problem with the heart function that affect the kidney function, and there's a kidney function that affect the heart function, basically that interrelated effect of both organs, basically the cardiorenal syndrome. So there are different type of cardiorenal syndrome. Type 1 acute cardiorenal syndrome is when there's rapidly worsening of the cardiac function, mainly congestive heart failure, which affect the renal function. That is acute cardiorenal syndrome. But when there's a process is chronic, which is very common, we have patients with congestive heart failure going on for months or years, and because of that, there's a renal function abnormality that's called type 2 chronic cardiorenal syndrome. So these are two topics we're going to talk about mainly. There are also type 3, type 4, and type 5, which are less important clinically. Type 3 is when there's an acute renal failure because of any reason like a rapidly progressive glomerulonephritis that can affect the edema, then can affect the heart function, that type 3 or acute renocardiac syndrome. When this process is chronic, then it cause type 4 or renocardiac syndrome, or type 5 when there's the same disease affecting both organs at the same time, like amyloidosis or even diabetes or COVID-19, that's called type 5. So again, mainly we'll be talking about type 1 and type 2. So basically, if you see that acute heart failure when it happens, there's an arterial filling volume decreases, and also there's a renal perfusion also decreases. At the same time, there's a renal congestion because of CVP increase, that increase intra-abdominal pressure, and because of that, there's a venous congestion that can cause or participate or contribute to renal failure. Basically, two main mechanisms is that decrease arterial filling volume or renal perfusion and increase renal congestion. That is basic concept of cardiorenal syndrome. And because of that, these things happen. There's a vasoconstriction of the renal vasoconstriction, hyperperfusion, reduced renal blood flow, and reduced GFR, and that affects the renal function. So here's again, I will describe in a little more detail what happened when there is a heart failure. So you can see that when the left heart dysfunction, a patient who has congestive heart failure with the low ejection fraction, because of that, there's a neurohumoral effect because of that. There's an increased activation of vasopressin, renin-angiotensin system, and sympathetic nervous system all increase. Because of that, there's a vasoconstriction, sodium and water retention, and decreased renal perfusion and ischemia that happens. At the same time, there's some other hormones or protein they releases that is to protect that effect. The release of natriureteric peptides, bradykinins, and prostaglandins, which are vasodilator prostaglandins. And these are also affected. They're actually to counter effect this, but this effect is predominant in patients who has Cardiorenal Syndrome. That's why these all actors are predominant effect. So from one end, you have perfusion issue from the left heart failure that affects of these decreased renal perfusion and neurohumoral effect. At the same time, because of heart failure, there's a right heart dysfunction, and that increase the renal vein pressure. Like we have hepatic congestion, same time we have renal congestion. So in both sides, because of increased renal congestion and decreased renal perfusion, that affect the renal function. So that is basically pathophysiology of cardiorenal syndrome: reduced renal perfusion and neurohumoral adaptation or maladaptation. Again, RASS system, increased sympathetic discharge, and then increased renal venous pressure and right ventricular dilatation and dysfunction. When there's a right ventricular dilatation dysfunction, that because of that, there's a dilatation of the right ventricle that moves the interventricular septum towards the left ventricle, and left ventricle, the space for distension is reduced. That's why the cardiac output also decreased because of septum moved towards the left ventricle. That's one more effect when the patient has congestive heart failure or right ventricle dilatation. So basically what happened that when there is congestive heart failure, there's a renal blood flow decreases. At that time, initially, the GFR is preserved. Because there's a adaptation to that, there'll be increased renin-angiotensin system release. Because of that, the efferent arterioles will be constricted. So glomerular filtration rate will be preserved. And that's why initially the GFR is not reduced. And that what happens when you give ACE inhibitor or ARBs, and that efferent arterioles are not constricted anymore. So the filtration fraction decreases, and that causes slight rise in PU and creatinine when you give ACE inhibitor or ARBs in a patient with congestive heart failure. So what happens to patient with preserved ejection fraction? So in that case, there's not study showing any problem with the decreased perfusion because there's no drop in blood pressure. So it is thought that whether there's a decrease in perfusion of the kidneys, it's not known, probably not. So there's a difference between the pathophysiology of the patient with preserved ejection fraction and reduced ejection fraction. So in patient with reduced ejection fraction, they're both mechanism participate in renal failure, like decreased perfusion, at the same time, increased congestion. While patient with preserved ejection fraction, probably the decreased perfusion is not the main factor, but the increased renal congestion is the main pathophysiological factor which affects the renal function. So basically, this is explaining the same thing, probably here, how the increased right ventricular failure or congestion increase or decrease the renal perfusion. So here's the glomerulus, which are encapsulated, and when there's an increased venous congestion, there's a outside the interstitial edema that actually putting pressure on the tubules. So this pressure is increased, so the perfusion pressure is also decreased. So that can cause the increased BU and creatinine. So if you give ACE inhibitor ARBs, so this is a afferent arterioles, and this is also otherwise constricted, that is not constricted anymore. So this is not constricted anymore if you give ACE inhibitor. So that's why the perfusion pressure also decreases, and then you can see the slight bump in BU and creatinine. So if patient is given non-steroidal at the same time, these are decreased renal blood flow because of inhibition of the vasodilator prostaglandins, and also decrease the GFR. So that is really a bad medication given the particular those patient who has compromised heart function, or patient who has CKD or prone to develop cardiorenal syndrome. So strictly contraindication of the non-steroidal medication in these patients. So this is one more picture to just to explain that process. This is an increased intra-abdominal pressure when patient has congestive heart failure, when they increase CVP. So that put pressure on the renal tubules. So proximal tubule pressure is increased, like here. So it opposes the filtration pressure, so it can decrease the GFR. So same thing again, patient with congestive heart failure with reduced ejection fraction, decreased renal arterial flow due to reduced effective circulatory volume. That is one of the cause of decreased GFR, and also marked decrease in CVP and passive renal vein congestion. So that is in congestive heart failure with reduced ejection fraction. While patient with preserved ejection fraction, there's a marked increase in CVP and renal venous congestion, but renal perfusion pressure is less affected as blood pressure is not low in that cases. So mainly the pathophysiology is that increase renin, angiotensin, aldosterone system and CNS activation. So there is a slight difference in mechanism of two types of congestive heart failure. So this already we talked about that these are different other modulator which are increased, or cardinal connectors. These are factor which increase the inflammation and RAS system and increase sympathetic activation. These are a very important role to play in pathophysiology of the cardiorenal syndrome. So how we manage that? Basically, not very complicated. We all know that what medication we're using that. Diuretics are used. Then we used renin, angiotensin, aldosterone system antagonist in patients with congestive heart failure, particularly with reduced ejection fraction. Then there's the role of inotropes, ultrafiltration, and improvement. So the only question is, what is the role of diuretics, and how much how much aggressive at one point it should be? Because sometimes we see the patient came with the congestive heart failure, you gave the diuretics, BU and creatinine increase, then what to do in that case? I'm just wondering, any question at this point? Hello? Wondering if everything is going well, or?
Ji, Assalamu alaikum, sir. Ahad here, sir. So Mufti Baleek has actually asked the role of, I mean, if in Pakistan, what happens is that if we are managing a patient with cardiorenal syndrome, patient is in overload. So the general tendency is that if the patient is on an ACE inhibitor, hum usko band kar dete hain usually. or agar if the patient is not on an ACE inhibitor, and this is something that the patient is in the A and E, yeah, he's admitted, so there is a general tendency not to start the patient on an ACE or ARB, and that is the question which Mufti Bali has actually asked. So would you put a patient on ACE inhibitor जिसकी creatinine पहले थोड़ी सी bump up हुई हुई है और diuretics के ऊपर है, या would you sort of hold that idea off until and unless once the patient has stabilized?
Okay, very important question. I think that's the probably number one question we always come in mind and people ask and we get a consult. So what to do at that time? Let me just go quickly on this couple of more slides, then we talk about this. Okay. Okay, so this is the diuretics. So diuretics, we always probably 90 to 100% patient who get congestive heart failure, they are given diuretics. That's the first treatment to unload the patient. So when we give patients with the congestive heart failure, when we give diuretics, and sometimes happens that BUN creatinine rises, and some patient BUN creatinine is not affected, and some patient actually improves with BUN creatinine. So those patient BUN creatinine is improves. That means those patients had renal congestion. When congestion is relieved, that BUN creatinine improved. So the question is that whether when we give diuretics and BUN creatinine rises, is that really bad, or what's the short-term and long-term consequences of that? So basically, to summarize what we're going to talk about, that if you have patient who very openly, very obviously, clinically have volume overload, and you give diuretics, and if BUN creatinine rises, you should not be worried about. Actually, that might not be a bad sign, as long as patient is diuresing and his volume is decreased and patient's congestion is being relieved. So there are many studies actually shown that effect, that if patient BUN creatinine rises as a result of diuretics, a patient who is obviously volume overloaded, that is not a bad sign at all. So this is basically another study when shown that when patients who are treated with congestive heart failure, diuretics, and increased hemo concentration because of increased albumin and increased hemoglobin, that show patient is dried up a little bit, and also BUN creatinine rises, that actually improve the survival of those patients. So this slide show again that patient who has no hemo concentration, GFR didn't increase, and patient who has hemo concentration increase, aggressive diuresis, and worsening renal failure, renal function actually, not failure. So in this patient, but if you see the survival, patient who had hemo concentration, BUN creatinine rose because of diuretics, they actually survival was better than patient who was not aggressively diuresed and hemo concentration was not increased. So this is another studies which shown that when patient has aggressive diuresis, and that actually did not worsen their survival or outcome. So this patient is aggressively diuresis, their BUN creatinine increased, but when they have other biomarkers of renal tubular injury, they did not increase actually. So even those patients who has acute kidney injury biomarker increase, they actually did better. In this slide, you can see that these are patient red line, they have best outcome. But these are patients who has increased BUN creatinine and increased injury biomarker as a result of diuresis. But patient otherwise without diuresis, if they have these markers, then it's a bad sign. But if you have patient who you're treating and BUN creatinine rises, to some extent, that is not a bad sign. So it means that you should not be too worried about and when treating aggressively with diuresis. So one question again, what loop diuretics are available in Pakistan other than Lasix? Any other like a Bumax or torsemide? Probably not.
No, Dr. Wes, these are not available in Pakistan.
Okay, that's fine. So I will not. These actually a lot of studies show that we use this torsemide a lot, and a lot of studies show that this is a better diuretics.
Yeah. डॉक्टर अवैस, आई थिंक थोड़ा सा टेक्निकल डिफिकल्टी ये थी कि आपने मेरे ख्याल है जो डायोरेटिक्स की जो भी स्टडीज की बात कर रहे थे ना, वो हमारे एंड पे स्लाइड आ नहीं रही थी, बिकॉज डॉक्टर अली हैज आल्सो
हाँ
पोस्टेड कि जी हम लोग एक्चुअली उस स्लाइड पे, हमें स्लाइड आपकी वही नजर आ रही है इस टाइम पे, जो मैनेजमेंट जिस पे डायोरेटिक्स, रास, आइनोट्रोपिक ड्रग्स और अल्ट्राफिल्ट्रेशन लिखा हुआ है. सो योर स्लाइड्स आर फ्रोजन एक्चुअली फ्रॉम आवर एंड, सो जस्ट वांटेड टू हाईलाइट दैट.
Okay. So basically, let me just go quickly. I think while you get out of more with more like discussion rather than these slides. I think I let me just go quickly a couple of more points and then open up the discussion. So this is another treatment, very important aspect of treatment. We give angiotensin 2 or basically this is a Entresto, uh, which are very important medication for the last couple of years. We're using that patient with congestive heart failure, and it has a role in Cardiorenal Syndrome also. So in the treatment of congestive heart failure, there are two main mechanisms: is to block the RAS system and to block the CNS system. So with CNS system, you block with the beta blocker, and with the RAS system, you block with ACE inhibitor blockers or ARBs. So these are basically, again, with patient who has reduced ejection fraction, not with preserved ejection fraction. So here's the mechanism again, the angiotensin, and then renin change to angiotensin 1, and then it converts to angiotensin 2, and that actually causes all the bad effect on the patient with congestive heart failure, like increased sympathetic discharge, increased sodium retention from the kidneys, vasoconstriction, increased aldosterone secretion, everything bad you can imagine, then it caused by angiotensin 2. At the same time, so that's why the blockage of RAS system is so important in management of congestive heart failure. So the treatment is ACE inhibitor, ARBs, or ARNI, which is Entresto. Okay, here's the thing: the heart failure, this again, the renin-angiotensin system, everything ultimately caused by angiotensin, vasoconstriction, blood pressure, high sympathetic discharge, increased fibrosis, and sodium tension. At the same time, there are some protective mechanism also, that is natriureteric peptide system. Okay, these are released. They actually try to counteract the bad effect of the RAS system by causing vasodilation, keeping blood pressure low, reduce the sympathetic tone, and reduce aldosterone level. So these are basically cleavage by or broken by neprilysin. So if you have a medication which inhibits the neprilysin, that is sacrobetril, that actually prolong the effect of these good peptides. So that's why this drug, which has combination of ARBs blocker and neprilysin blocker, that actually had the better outcome as compared to just ACE inhibitor or ARBs. So that is what we're using nowadays, that valsartan and sacrobetril. So one thing I want to mention about this when you use Entresto, the valsartan, the sacrobetril valsartan combination tablet is more bioavailable than valsartan in the other marketed tablet formation. So in that combination, if you have a 25 milligram of valsartan, that basically is as effective as 40 milligram otherwise. So 51 is effective 80, and 103 dose as 160. So that keep in mind when patient blood pressure goes low, that you need to cut down the dose, because the valsartan in that combination is not only 26 or 51 milligram, these are 40, 80, and 160 milligram. So basically, there's a role for inotropes. Again, I don't think.
Excuse me, sir.
Yes.
सर कुछ लोग स्लाइड नहीं चेंज हो रही, स्लाइड्स को चेंज.
Okay, let me see.
स्टॉप करके दोबारा शेयर कर दें सर.
Oh, I think now it should be okay, right? You can see that now?
Yes, we can see now.
Fine sir, fine.
Okay. Yeah, that was the thing. So basically, जो miss हुई आप लोगों से, that is actually, these are the slides. I think I was talking about these slides. You didn't see this before, right? Can you see this slide now?
Yes,
Yes.
we can.
Yes.
Okay. So I'll be finishing up in just a couple of minutes, then we can talk about, I know this is meant to be only for 25 minutes, it's a bit longer, that slide part. So basically this is just to revise that system again, that basically RASS system. So angiotensin, convert to angiotensin 1 by renin, and then angiotensin 2, and then angiotensin 2 actually start all the undesired effect on the heart and kidneys, like increased sympathetic discharge and aldosterone secretion, sodium retention, arterial vasoconstriction, and area excretion. So treatment is ACE inhibitor, ARBs, and ARNI. These are heart failure, so increased renin angiotensin system activation, cause all the unwanted effect, and that is blockage by this medication valsartan. When you combine with this medication sacubitril, this is basically an inhibitor of the neprilysin. What is neprilysin? Basically, when the heart failure happens, there's some peptides, neuropeptide release, which are basically try to counteract the bad effect of RAS system. But all the neuropeptides are metabolized or catabolized by neprilysin. And if you inhibit neprilysin, you can have prolonged effect of this desirable neuropeptide, cause vasodilation, low blood pressure, reduced sympathetic activity. That's why this medication is developed, which is combination of valsartan and sacubitril. So this is what I tried to tell you, that valsartan in this combination, sacubitril, valsartan, or Entresto, it is more potent than the dose suggests you. So 26 milligram dose of valsartan in that system is more potent, as the bioavailability is more. So 40 milligram equal to, and 51 milligram in that combination with Entresto is 80 milligram, and 103 milligram is 160 milligram. So that keep in mind when patient blood pressure dropping. So this is because these doses are a bit higher, as suggested by the dose in that combination. So basically, rest of the slides are just proving that this combination, this Entresto compared to ACE inhibitor ARBs has no deleterious effect or renal function. Basically, it's a bit more potent blood pressure medication as compared to just ACE inhibitor, because there are two medications which causing low blood pressure. Then the role of inotropes, and I don't know whether we need to go in detail or not, because I don't think in Pakistan using a lot of inotropes or Milidon or dobutamine for a patient with cardiogenic shock. Are we?
We do use dobutamine,
Okay.
but not
But-
milrinone.
Not Milidon. Okay. So basically, there are three inotropes are used in cardiogenic shock. So basically, we talk about cardiogenic shock in the related to Cardiorenal Syndrome. In some cases, these medications are indicated, which is inotropes, which are mainly two. We don't have that calcium sensitizer available in US, which is only in Europe. So mainly we have dobutamine and Milidon. We use Milidon more. But again, the routine use of either of these inotropes study has shown no any benefit. Actually has shown some mortality increases. So if you're not using much dobutamine or Milidon, that's okay. But in some cases, for a short period of time, these are indicated when patient has a cardiogenic shock. So again, the multiple studies shown that the routine use of these inotropes has no survival benefit. So, but if we use that, these are out of these two medication, if you have patient who has hypotension and you need to use the anadrops, dobutamine is better medication that clinical scenario, and patient renal failure also. It's a little more detail that how use it, but I think because Pakistan Miliron is not being used, so I think I would skip that discussion. So basically, let's go back to the question answer session, and we can, I think, I'll be able to talk more about that. So the first question is that a patient who come with congestive heart failure, patient is on ACE inhibitor ARBs, and what to do at that time? Should we continue? Should we hold it? Should we restart it? So the short answer is when there is a patient who has sudden rise in BU and creatinine, patient is stable, patient was on congestive heart failure, patient on ACE inhibitor. Let me just remove this. And patient admitted to hospital. At that time, BU and creatinine is rising. At that time, there's an indication to stop those medication, ACE inhibitor or ARBs. And you should resume this medication before patient leaves the hospital. Okay, and patient's BU and creatinine stabilize, then you start it again. But at the same time, when there's an acute kidney injury or acute rise in BU and creatinine, and patient needs aggressive diuresis therapy, that's the time you should hold ARBs or ACE inhibitor or ARBs, or even patient on Entresto, because these patients, they have very compromised renal perfusion. And the most deleterious effect on their renal function and also outcome is that low blood pressure. So if blood pressure goes low because of ACE inhibitor ARBs in this patient, in that case, that is outcome is not good. So basically, I would hold, not I would just, the recommendation is to hold ARBs, ACE inhibitor, or Entresto when there's sudden rise in BU and creatinine while patient is getting treatment for congestive heart failure. But again, don't forget to resume it when before patient leave the hospital, because their outcome is affected when you don't start those medications.
Dr. Wali here, can you hear me?
Yes, yes.
Yeah, I wanted to ask two questions. Basically, we could not see the slides, but you said that diuretics were actually associated with better patient survival. So I wanted to ask whether this better patient survival was seen along with better renal survival as well, because you could make a case that they came out of pulmonary edema, and at the end the patient was at least saved and stable. But did it translate into better renal survival as well? And the second thing that I want to ask is, can spot urinary sodium differentiate between the pathophysiology being reduced cardiac output versus venous congestion?
Actually, let me ask you answer your second question first. When we see patients with congestive heart failure, you're treating with Lasix, and sometimes the BU1 creatinine goes high, and BU1 creatinine ratio goes high. So you're not sure whether this is a high BU1 creatinine ratio is because of dehydration or because of increased congestion, which you cannot. Basically, in both clinical scenario, the BU1 creatinine ratio and the urine sodium is pretty much same. You have decreased urine sodium, you have increased BU1 creatinine ratio in both circumstances. So you have to see patient clinically, is patient is kind of dry or patient is wet. Because of increased sympathetic discharge, because of increased level of angiotensin II, there's an increased BUN absorption and increased sodium absorption. And that is also the same the case in patient who was dehydrated. So your first question, whether that increased BUN creatinine or decreased renal function, whether that is, initially that is the renal survival is also better, or just as a whole cardiac survival, right? That's your question?
Yes, exactly. That was what I was asking.
Okay. So basically, there is no question that the cardiac survival or patient outcome is better. that is pretty much is all these. Studies shown that patients' survival and cardiac survival and outcome survival. Where the patient's renal survival, the studies shown that when you have increased aggressive diuresis, when patient leaving hospital in a week or so, at that time probably his or her creatinine is still high. The renal function still not back to baseline, but in 60 days, majority of the patient, their renal function improves with the to baseline. But there are some patients with the renal function does not improve to baseline with aggressive therapy. But if you see the patient, the outcome, how long patient will survive, that definitely improves by aggressive dialysis therapy. Okay, I will actually insert myself. I log in myself, so I think there are a lot of some problems. So I'll be back in maybe less than a minute, please.
Okay, so while he's away, I just had posted a question there. Okay, Dr. Ali, if you're there, sir, आप एक दिन में कितनी ज़्यादा आप दे देते हैं Lasix? I mean, we've seen कि हमारे जो ये cardiothoracic surgeons हैं, वो 100 mg per hour की infusion start कर देते हैं.
Okay.
And we've actually seen the उससे skyrocket कर जाती है. Oh, so you're back. Can you hear us, Dr.
Yes, yes. Sorry for all this.
Okay.
I know I'm not very.
No, okay. So I'll direct my question to you, so ताकि वो बाकी भी देख लें. So my question was कि speaking of diuretics, so how high are you willing to go safely in a 24 hours? So what essentially what I mean by that is that in the cardiothoracic units we do see कि जी cabbage हुआ, urine नहीं आ रहा, BP अगले दिन सुबह आके देखा तो 100 mg per hour के ऊपर infusion चली होती है Lasix की. फिर एसएमआईडी एंड लो एंड बिहोल्ड उसकी वजह से फिर क्रेटिनिन वगैरह भी स्काई रॉकेट की होती है. इज देयर अ मैजिक नंबर कि जी बस ये सीलिंग है, इससे ऊपर नहीं जाना चाहिए 40 mg पर आवर के ऊपर से, या व्हाट इज योर एक्सपीरियंस इन दैट? और बाकी वो भी शेयर करना चाहते हैं तो बता सकते हैं.
सॉरी, आप लोग मतलब कितनी इन्फ्यूजन किस रेट पे आप देते हैं वाटसन में?
So I can only speak for myself. मैं usually 40 mg per hour से ऊपर नहीं देता.
40 मिलीग्राम पर आवर.
मिलीग्राम अगर मैंने इन्फ्यूजन में देनी है. बाकी तो बोलसेस में तो आप सुबह दोपहर शाम टीडीएस के अंदर 100, 120, 140, इवन 200 mg 8 आरली भी दी जा रही होती है. उससे ऊपर मैंने कम ही देखी है, एटलीस्ट इन लाहौर. बाकी ज़ाहिर दूसरे प्रोविंसेस वाले भी इसमें हेल्प कर सकते हैं. तो बोलसेस में मैक्सिमम मैंने 200 mg 8 आरली देखी है, और 40 mg पर आवर से ऊपर इन कंटिन्यूअस जो लेसिक्स ड्रिप होती है नहीं होती देखी. सो व्हाट इज योर एक्सपीरियंस ऑन दैट कि क्या आपकी सीलिंग इफेक्ट है उस पे?
Actually, we very, very rarely go to 40 milligram per hour. Very rarely. I mean, actually, this is definitely a ceiling, and I have done actually 50 in my life, 50 milligram per hour, but I think that's useless. I think normally we start like 10 milligram per hour, and we go 20 milligram per hour. After that, very rarely we go to 30 or 40. Actually, I think in the last couple of years, I have not gone more than 20 milligram per hour. So if that is not enough, that means that that is enough. Patient is not responding. you need to go to other options. Other options mean obviously you have to add some thiazide diuretics, or even spironolactone you have to add. And if that is not working, then you have no choice other than going to ultrafiltration or dialysis. So in
Uh,
my
may
experience,
I respond to this?
sure, absolutely.
Um, well, for Lasix, it is known that a dose of higher than 6 milligram per kilogram will not work if it has not worked at that dose. And the risk of giving ototoxicity is much higher if you exceed that dose. So I think it depends on that body weight of that person. If it's a very large person, you can try. I think the ceiling dose that is used is around 240 milligrams in a day for those who are not on dialysis
I mean, 240 mean that 10 milligram per hour, right? In
for
a
a
day.
whole day.
Yes.
Yes, so if you increase the infusion rate, then you can't continue it for the whole
Basically,
day.
I mean, our experience or the studies shown that when the ototoxicity, they have not reported to my, what I study, I went through that any patient less than 1 gram a day of Lasix. So you have pretty high ceiling before you are worried about furosemide causing ototoxicity. So 10 milligram per hour between 240 milligram per 24 hours kind of low dose. You can easily go to 20 milligram, which we commonly go on 20 milligram. After that, 30 milligram, 40 milligram, you can go without worrying too much about ototoxicity, but the probably will not be very effective because the ceiling is between 20, 30, and 40. So if you increase to 40 or 50, you probably will not get any benefits more than 20. So you have to add some other diuretics like a thiazide diuretics to have more potency in dialysis.
Well, that also depends on the use of Lasix. If it is a chronic user, then the distal tubule gets adapted. And that is when thiazide work in combination with Lasix. But if someone does not have a GFR, not like very few functioning tubules, then Lasix might not give you that diuretic effect that you want. That is my take on this.
Okay.
Yes, I think some studies have used up to 1000 milligrams per day. And some authors have also mentioned that ototoxicity is mainly dependent on the rate of infusion, meaning to say that it should not be more than 4 mg per minute, because if you cross this threshold, it can cause ototoxicity.
Yes, absolutely. Actually, the ototoxicity is very high dose. If you are on that, only then ototoxicity. Or if you, obviously, this patient is taking some other medication along with that, like gentamicin or something else. Ethacrylic acid, basically, which we have also another options. That's more ototoxic than any other loop diuretics, but we don't use that unless patient has, allergic to medication, self-medication, anaphylactic reaction to that. So you're right. Unless patient is very high dose, 1 gram for 24 hours, ototoxicity is not a concern.
Um, One common fear that I have noticed among physicians whenever I go out to give lectures is that Lasix acutely drops blood pressures. My take on this is that unless you diurese that much that you become hypovolemic, Lasix will not give you hypotension. What do you say?
You are absolutely right. Basically, there's a slight difference between thiazide diuretics and loop diuretics. Thiazide diuretics are somewhat venodilator or vasodilator. Loop diuretics by itself is not vasodilator. So you can cause hypotension by loop diuretics only by decreasing the perfusion of volume. If the patient is volume overload, the chances of causing low blood pressure is very, very low with loop
Okay.
diuretics.
Now, another question is about the use of digoxin, the old time, well tested digoxin as an inotrope, especially in end stage kidney. Works wonders for me.
basically, we don't use much digoxin here anymore. Okay, because we have since this new medication ACE inhibitor, ARBs, and this Entresto came in, the digoxin role is gone down significantly. Okay, so we don't use much. So particularly in patient who has renal failure, it's also, I think, better to discontinue that because the risk of these toxicity are much, particularly with the potassium, if it's a hypokalemia or hypercalcemia in that case. So the benefit or the survival benefit are not significant, but your potential toxicity is a lot with the particular patient with the CKD 4 or 5.
For
Yeah.
those
Dr.
patients,
Abbas, sorry, please carry on.
no, no, I was just saying about those patients who are on dialysis. They get dialyzed and their potassiums are usually well controlled. If you use a very low dose, like 2.5 micrograms every other day of digoxin, we have tried this on many children with with end-stage kidney disease, and it just brings them up. It's a very good inotropic medicine and a very old timer. That's why usually people have not done any new studies on it. But yes, you're right. Usually people are scared of the toxicity, which is also very rare.
And sorry,
Doc,
just to I'm sorry, but sir, इस चीज पे पूछना था
जी,
मैंने कि just
please,
to sort of
please.
carry on with that, so when you say कि जी sir, they you know they get better, they get better in the sense that their blood pressure, you're able to maintain their blood hypotensions की आप incidence कम कर लेते हैं, या किस फिगर से बात कर रहे हैं कि जी मैं अगर उसको मैं अल्ट्रा फिल्ट्रेट करने की कोशिश कर रहा हूँ और मिजरेबली फेल कर रहा हूँ क्योंकि मैं बीपी मेंटेन नहीं कर सक रहा, तो उस चीज में
Yes.
डाइजॉक्सिन का फायदा है या किसी और चीज में कह रहे हैं सर?
Yes, and that they usually come with abdominal pain because their livers are getting stretched and congested. So once you give them this digoxin, this you can feel that the JVPs and the livers, the engorged livers, they go down. Clinically, their ejection fraction improves.
Okay, I mean, as I say that we are actually getting away with the from digoxin. Hardly any patient is on digoxin now because we have more and more. I'm studying showing that the other medication like ACE inhibitor, ARBs, and Entresto, they are much beneficial
Yeah.
for those patients. But still, some patient has because of the AFib and they have a rate control and also at the same time for congestive heart failure maintaining. So I mean, can be maintained, but again, with
Yes,
better medication available, there's no goal for that.
we also use the ACE inhibitors as first line. Beta blockers also, the beta blockers and ACE inhibitors as first line. And if someone does not respond, then as an inotrope, just adding a little bit of digoxin on every other day helps in my experience. So that's a third line or a fourth line drug. Since we do not have milrinone, dobutamine is difficult to monitor. We do not have this I can't even pronounce
Interesting.
that, androsterone. So the only choice we are left with is this.
No, I thought Entresto is available in Pakistan. Is it not, or is it available?
So Entresto is easily available in Pakistan, sir. Entresto लाहौर में तो बहुत easily है, even locally भी बन रही है सर अब तो, सर बाहर से नहीं आ रही.
Acha.
I
So
think yeah, it's
बिल्कुल,
available.
easily available, easily available है. डॉक्टर अवैस, मैं पूछना चाहता था कि आप IV bolus versus infusion of Lasix में से which one do you prefer? I mean, are
I
they
mean,
the same or?
actually, has been over the last 20, 25 years. There has been actually my preference has changed because I strictly try to follow whatever the evidence-based medicine is. I don't go those people like, oh, this work for me, or I have to be evidence-based medicine. And that evidence has been changing also over many years. Initially, we used to use bolus a lot when I was in training in fellowship. I'm talking about late 90s. Then study came out, a big study, that there's no benefit of giving bolus. I mean, bolus is as good as as the infusion. So we cut down. But again, some studies shown that small studies shown that infusion is better. So currently, my trend and my colleagues' trend is that we use infusion more now as compared to what we were doing for last about 5 years ago. So there's some potential benefit. I cannot prove with some big studies as compared to boluses that you can have the same effect with the lower 24-hour of Lasix by infusion. And also the half-life of Lasix is very short, as you know that. And a patient in hospital, I think we should use, if we're using IV Lasix, we should not use once a day or even twice a day. It has to be like 3 or 4 times a day, IV Lasix. So because it's a short, very short half-life, and if you have a patient on infusion, then I think it gives you a continuous some dose to work on to use. But I'm not saying that one is better than other. Either way, you are okay.
Sir, I needed to ask a question.
Yes, please go ahead.
The question would be regarding the discussion. It was a wonderful discussion regarding the cardiorenal syndrome. My question would be that once you stabilize the cardiac function and then the creatinine comes down to the baseline and then you restart or reinstate the ACE inhibitors or ARBs or the ROS inhibition to the patient, and then the creatinine gradually starts rising again up and it goes beyond the 30% that we consider as the safety net for us, that okay, fine, it can go up to that extent. But if it keeps on going, then what would be our management plan for that patient regarding the ROS inhibition?
When this keep on going on, first of all, what I would do on this, the my colleagues, when we discuss this problem, first of all, you need to find out whether anyway we can cut down the diuretics dose on those
Okay.
patients. Okay, before we're cutting down the ACE inhibitor or ARBs. Okay, because the potential benefit of ACE inhibitor or ARBs are so much that you try your best on survival, overall survival. I'm talking about is so much that you like to keep them as long as you can. And when there's a slightly overdose of diuretics, the BUN creatinine goes high even more in the presence of ACE inhibitor or ARBs. So if a patient on this medication, BUN creatinine going high, so try first to cut down the diuretics if possible. Okay, if that stabilizes the BUN creatinine, then you're okay. But if keep going up, you have no choice other than stopping for the time being or cutting down the dose of ARBs or ACE inhibitor. If you're going beyond like a 30 or even 50% in that case. So again, first cut down the diuretics. If that doesn't work, then cut down the dose if keep going the BUN creatinine in the presence of ACE inhibitor or ARBs. So you were saying that.
Let's say that the diuretics, you've cut down on the diuretics. Still, by introducing valsartan, it is the creatinine BUN goes above the 30% mark. But then you have no alternative but to stop it. Am I right in saying that?
Yes, yes. Or cut down the dose first. Try to cut down the dose, and because some dose is better than no dose. And if that doesn't work and BUN creatinine keep going high, and you have no other explanation, then you have no choice other than stopping or cutting down the dose of RASs blockers.
Dr. Vance, the cutoff value of rising serum creatinine is 30%? Urea and creatinine, 30%?
That's rough. I mean, it depends on your. I mean, sometimes you let it go by 50%. Sometimes, like generally, is a 30%, right? I mean, like patient has creatinine of baseline creatinine 1.5 and patient creatinine rise to 1.8. It's okay. That's fine. That's actually acceptable. That actually have better prognostic sign as compared to patient whose creatinine does not increase when patient is on BUN creatinine. But if patient creatinine is going from 1.5 to 2.5, that's a bit too much.
Okay.
So as far as the inotropes, I'm talking about milrinone or dobutamine. If you don't have, believe me, there is not much role, and particularly in patients with the chronic congestive heart failure, there's no role in chronic maintenance of congestive heart failure. There's an outcome showing that the outcome is actually bad as compared to not doing this, but there is a definite role in some patients who come with the cardiogenic shock. We use milrinone more than dobutamine for a very short period of time. And their role is that if patient who you want to be keep, symptomatic free, although you would know that it's not going to improve the survival, and those patients are okay to be put on Millenon because definitely the symptom improves on Millenon. We have patients who are on long term, like for months and months, and home on Millenon infusion. But also the same thing can be done for with the dopitamine, not dopamine, dopitamine. If you have patient who you want to, improve patients, EF is very low, like 10-15% patients, you want to improve the patient symptoms, you can give patient dopitamine infusion for 7 or 6 days, and that will most likely will improve patients' symptoms. And if you stop that medication at that time, the positive effect symptomatically actually lasts for almost a month. So that patient, but you would know that you are not adding patient survival with giving dopamine on this patient. Symptoms do improve many times.
Is there any role of mineralocorticoid antagonist in these conditions?
Mineralocorticoid has a very important role, which, let's talk about mineralocorticoid. Very, very important role. Basically, again, we're talking about two type of congestive heart failure. One is with the reduced ejection fraction, one is preserved. Basically, let me just get out of the way the preserved ejection fraction. It has no particular treatment. There's no single treatment you can say that this is a good for patient congestive heart failure with preserved ejection fraction. Neither ACE inhibitor has any proven role, neither spironolactone, neither this Antagonist has any particular role other than just neither beta blocker has any particular role. Basically, all you can do to prevent that happening, like control of hypertension. So as for the congestive heart failure with reduced ejection fraction, there are a lot of medication available, and one of the very important medication is this MRA inhibitors, like spironolactone. So any patients who are on ACE inhibitor, still second option is to add spironolactone to that patient. Basically, that has multiple studies shown that very, very impressive that it improves patient survival on those patients with reduced ejection fraction. Even patient who was on Antagonist, you can add that also, spironolactone. That's not contraindicated. Although, obviously, we know that the ARBs and ACE inhibitor should not be given both together. That increase the mortality. I couldn't hear, I think somebody asking a question. The voice is not clear. So let me ask a question. So when you have a patient in Pakistan with an ICU or hospital, and can you hear me? Okay.
Yeah, we can hear you. मेरे ख्याल है वो बीच में distortion आ रही है. If you can probably mute all करके your sort of main host आप है mute all कर दें तो मेरे ख्याल है बेहतर है. Because आवाज नहीं आ रही Q com पे. हाँ जी अब ठीक है.
Okay. Okay. Any question from anybody or did I?
जी, basically mineralocorticoid को मैं specifically इसलिए भी पूछ रहा था कि जो spinal lectone है ये aldosterone receptor antagonism के बाद it takes time for this drug to work because the signal will go to the nucleus and it will start producing the ENaC, etc. So in such conditions, sometimes we use amiloride, which is available in combination with furosemide, because in acute conditions, your spironolactone will probably not help in those 4 or 5 days initially. So what's your take on that?
I mean, amiloride, there's no study which shown any benefit on that amiloride. I use amiloride in some other circumstances, but as for the Cardiorenal Syndrome or congestive heart failure, I have not seen any study which showing amiloride, because amiloride has a different mechanism of action as compared to spironolactone, and because spironolactone has many other effects also on heart by itself by decreasing the cardiomyofibrosis and angiotensin escape escape phenomena. So amiloride is a good medication, but in congestive heart failure, I'm not aware of any study which compare spironolactone compared to amiloride. But as a diuresis, yes, I mean, you're right. I mean, when your patient is on, loop diuretics, and patient is on thiazide diuretics, and still you want some more diuresis, and also, or you also counteract the hypokalemia or the metabolic effect of thiazide and loop diuretics. And for some reason, if you not able to get spironolactone, you can ask amiloride. And if there's a combination of amiloride and spironolactone available in Pakistan, you can use it. I have no experience with that. So I don't know whether anybody asking question. So my question is, in Pakistan, when you have loop diuretics giving IV or very high dose, and what thiazide diuretics are available over there?
Hydrochlorothiazide is available in Pakistan.
Okay.
And thiazide like diuretic metalazone.
Metalazone available. Okay.
Metalazone is available.
There's no intravenous thiazide diuretics available there, right?
No.
Chlorothiazide is not available. Okay. Okay.
In my experience, when you will give the metalazone in combination with the furosemide, you will get a very good diuretic effect if the furosemide is not working well, and you will add the metalazone.
Absolutely, absolutely. So one question, and I don't have a clear answer, but maybe you have. So sometimes we see that patient with hyponatremia and patient with congestive heart failure. Obviously, that is volume overloaded. But sometimes I've seen that patient who are volume overloaded, but they have hypernatremia. The sodium goes high. Have you seen those cases? I mean, patient is volume overload. You give loop diuretics, and the sodium goes high to 150 in this range, 152.
Yes, yes.
What do you do with that?
Yes, possibilities. Yes, possibilities with giving that of the furosemide, and in the day or two you will get that of the hypernatremia, and still the patient is in a volume overload state.
So what do you do with that?
With that of the give IV dextrose.
I think we would just do a dialysis.
I mean, I'm not surprised that you don't have any answer, because I don't have either. Okay, because nobody has, and this is actually recently basically a phenomena we are facing. I mean, probably always there, but we're seeing more now. So there has been discussion among, you can say specialists or our discussions. So the pathophysiology is also not sure what happened. That there are some suggestion that it can happen because the patient has probably intravascular volume depletion as a third spacing, or at the same time These happen to only those patients whose kidney function is not normal. So because of probably tubular handling of water and sodium is messed up, and that happens. And the available options are, so you cut down your loop diuretics and give high dose of thiazide diuretics in those patients. So like metolazole, what normally dose you give? So give 10 milligram of metolazole, even 10 milligram twice a day, and cut down the loop diuretics. So if you're giving like 80 milligram twice a day of loop diuretics, cut down to 40 milligram twice a day, or no, but increase the thiazide diuretics. That theoretically and practically also improves to some extent this hyponatremia and hypervolemic patients. That's what we do on patient like this.
Okay.
Okay. You had a question. I think you were talking about what to do patient who had hypotension and patient needs dialysis. Like,
yeah. So I just wanted कि pharmacy या pharmaceutical वाली जरा cover हो जाता, because the next step would be that clearly. So I'll just run you through how I think what we do in Pakistan is that if there is such a patient जिसको acute decompensation है, we give them a diuretic, start with Lasix, उसको आहिस्ता आहिस्ता ऊपर किया, no response, we add metazolone और फिर देख लें कि क्या effect आ रहा है. So lo and behold, it doesn't help. Patient's EF is low. Debutamine ट्राई कर ली, या ये डाइजॉक्सिन वाला आइडिया सर ने जिस तरह बताया, तो मतलब ऑब्वियसली एविडेंस के बेस तो नहीं है, लेकिन एक्सपीरियंस के साथ टोटल एविडेंस के साथ तो बात की जा सकती है. बट द मेन थिंग वुड बी दैट आई वुड बी इंटरेस्टेड इन सॉर्ट ऑफ नोइंग कि जी अब उसके डायलिसिस के, डू यू गाइस जस्ट डू नॉर्मल डायलिसिस या स्लेड करेंगे आप उसको मतलब अंडरलोड करने के लिए? व्हाट विल यू डू? How do you guys play around with the machine? Do you look at conductivity? आप उसको क्या low efficiency dialysis पे डाल देते हो कि जी नहीं मैं extended daily dialysis करूंगा patient का? How do you guys go about dialyzing this particular patient जो overloaded है और अभी भी उसकी EF low है?
I mean, it depends on okay, this is an acute problem or chronic problem. Okay, so obviously patient has a chronic problem, so you have to look for some long-term solution to that. An acute situation, a patient is in ICU, patient has congestive heart failure, blood pressure is low, and you expecting that patient has some acute cardiac injury and patient will improve, then obviously you go to SLAD or CVVH or just call it SCUF, like just ultrafiltration with the CVVH machine for a few days. But most of the patients, they have long-term problem. You cannot just, you have to find out what needs to be done. We have, I'm sure you have many patients in your dialysis unit who have low blood pressure and you don't know what to do. I mean, you take some fluid off, blood pressure drops, and you don't know what to do, right? That you have very common situation.
Yeah,
right?
so that is exactly it. I mean, CRRT कहना तो easy है. I mean, CRRT
exactly.
in Pakistan is, वैसे तो acute setting में बात ही नहीं कर रहे, हम तो chronic setting के अंदर
Chronic
बात
setting,
कर रहे
yeah,
हैं.
exactly. So
CRRT
that's out of the way.
CRRT
Like CRRT,
acute में भी पाकिस्तान में क्या ही होना. लेकिन but that is what I would be interested. So मतलब essentially you would just increase the treatment time और उसको gradual ultrafiltrate करेंगे या कोई और चीज भी है? Do you guys play around with the temperature at all?
yes, we do actually. I mean, again, we don't have any magic, pill that you don't have that. So I'm not telling you anything different, but I can say the same thing what you guys doing. So basically, same thing. पहली बात तो ये है कि यहाँ पर those मतलब काफी ज़्यादा patient ऐसे होते हैं. There are a lot of patients like this. So those particular patients, what I do, and I'm sure they do that. If patient agrees to them, they come more frequent dialysis. Very frequently, these patients get 4 times a week dialysis, which is difficult in Pakistan. We are actually twice a week is like a struggle. So what we do like a short dialysis, like more frequent dialysis for those patients. Because if patient has very aggressive dialysis, you're trying to take off 2 or 3 liters in one setting, the blood pressure is going to do drop. The other option we have, which you don't have, there's a alpha agonist medication, midodrine available here, which we use very frequently without any evidence-based medicine, but it works. You give them half an hour before dialysis and blood pressure is maintained, or give 1 dose more during dialysis, and that maintains the blood pressure. At the same time, again, more frequent dialysis, and obviously we need to make sure the patient is not taking any medication at wrong time, which further lowers blood pressure. And some patients try to eat during dialysis. Actually, that's also should be discouraged because that actually causes hypotension when they try to eat while dialysis is going on. Temperature, definitely we use 36 temperature and slightly decreased temperature. They're shivering, but the blood pressure is maintained. We use that, but we don't use, I don't use like a sodium modeling or increased sodium. That doesn't work. That actually end up patient getting more thirsty and more sodium retention, and they drink more fluid in between treatments. So nothing new, same thing. What you guys doing, we are doing the same thing, but that's a problem. Dr. Farouk is here, right?
या जी अस्सलाम वालेकुम। मैं असल में बात कोई सुन रहा था, तो मैं ये कहना चाह रहा था कि दो तरह की सिचुएशन आहत जो क्वेश्चन आपका, एक तो ये है कि इफ यू हैव हाइपोटेंशन इन डायलिसिस, acute versus chronic setting के पेशेंट acute setting में सेप्टिक है तो वो मतलब आई थिंक वी हैड अ डिस्कशन ऑन दैट, एंड देन chronic settings में अगर हाइपोटेंशन है तो उसको कैसे मैनेज करना है, और द अदर थिंग वाज कि हाइपोटेंशन विद हार्ट फेलियर। तो आई थिंक जब वो कंजेस्टिव हार्ट फेलियर वाला पेशेंट है तो उसका आपको बहुत सारा जो फोकस है वो हार्ट के ऊपर भी करना पड़ेगा। आई थिंक समबडी एल्स मेंशन्ड अबाउट द डोब्यूटामाइन एंड देन फिक्सिंग द कार्डियोजेनिक शॉक। आई थिंक वो जो ये वाला पेशेंट है ये डिफिकल्ट है जिसके अंदर कार्डियोरेनल सिंड्रोम है। तो आई थिंक व्हाइल वी आर ट्राइंग टू रिमूव द फ्लूइड वी आल्सो नीड टू डू समथिंग फॉर द हार्ट। तो ये मेरे आई कैन इमेजिन इट मस्ट बी ट्रिकी, क्योंकि कभी कभी आपको यू नो द अप्रोच है कि भाई किसी को वो CRRT, if this is not available then what you do. I think it's very challenging to manage those patients who have low blood pressure, they are in bad cardiogenic shock, they are volume overloaded, so you have to work on multiple aspects के भाई उनका दिल का क्या कर रहे हैं, उसमें उनको कोई डिवाइस सपोर्ट अगर चाहिए या उनको cardiogenic shock के लिए कुछ चाहिए। I think those patients become like your nightmare. I can just imagine अगर आपके पास वो बाकी सारी चीजें नहीं है। लेकिन I think in जैसे जो भी resources हैं, I think जैसे अली उन्होंने mention किया है कि slow UF over 6 hours or maybe you know you do it daily and then give patient a chance. I think यही करना पड़ेगा। लेकिन फोकस यही है कि जो कार्डियोजेनिक शॉक का पेशेंट है उसको हार्ट को भाई किस तरह से करना है, क्योंकि किडनी तो वो सेकेंडरी इशू बन जाएगा ना। So I don't know. So the question, my question back to you is कि जो आपके कार्डियक फेलियर वाले लोग हैं या वो लोग उसको किस तरह से आपको हेल्प करते हैं इस पेशेंट में? Ahad, if you want to answer that, कि भाई आपको ये वाला मरीज जो है आपको कार्डियोलॉजिस्ट से क्या सपोर्ट मिलती है, वो कोई मतलब उसको किस तरह से मैनेज करते हैं?
नहीं, सो अक्यूटली में तो मतलब कार्डियोलॉजिस्ट हमारी उसमें कोई इतनी हेल्प कर नहीं सकते, बिकॉज ऑल दे कैन से अंडर द करंट सर्कमस्टांसेस इज कि जी ये दो ही चीजें दे सकते हैं ना जी, वो या तो वो कहेंगे कि जी एंटरिस्टो दे दें, बट एंटरिस्टो लेट्स बी फेयर इट इज अ ड्रग व्हिच कॉजेज हाइपोटेंशन। सो मतलब वो क्रॉनिकली तो चीज ठीक है, मतलब इट्स एन एस इनहिबिटर, मतलब इट इज एंजियोटेंसिन रिसेप्टर ब्लॉकर देयर, सो यू कांट यूज एंटरिस्टो in the acute setting because it will not help. And so the cardiologists do not usually help us out in this, and they actually leave it to us that it's on us, क्योंकि उनके पास है ही कुछ नहीं, मतलब उनके पास या डब्यूटामाइन है पाकिस्तान में या दूसरा फिर वो डाइजॉक्सिन ही आ जाती है जो डॉक्टर अली ने बात की। लेकिन वो यही है कि वो डायलिसिस के ऊपर डाइजॉक्सिन देते हुए कार्डियोलॉजिस्ट तो बहुत डरते हैं और वो उस पर खामोश ही रहते हैं कि आप खुद देख लें देनी है कि नहीं देनी है, इसकी कोई इंडिकेशन तो नहीं बनती। बिकॉज over a longer period of time what they can probably say is कि आप देख लें कि स्ट्रेस एको करवा लें या थैलियम स्कैन करा लें कि मे बी हम अगर इसकी एंजियो करके कोई ऐसी है कि स्टेंट कर दें तो कोई इसकी शायद जो वॉल मोशन एबनॉर्मेलिटीज हैं वो अगर बेहतर हो जाए उससे तो हो जाए। अक्यूट सेटिंग में आई डाउट कि इवन अगर, क्योंकि हमारे पास तो इधर कोई ऐसी चीज नहीं है कि एलवैड या ऐसी कोई चीज हो कि जो मैकेनिकल डिवाइस को फिट कर दें जिससे ईएफ फौरन बढ़नी शुरू हो जाए। सो द कार्डियोलॉजिस्ट इन समरी डोंट हैव एन आंसर फॉर अस, और वो हमें ही देखना पड़ता है कि क्या है। एक आपने देखा होगा कमेंट किसी डॉक्टर साहब ने लिखा है जो कि हम लोगों ने भी एक्चुअली इधर ट्राई किया हुआ है, वो ये है कि हम लोग अगर तो पेशेंट बिल्कुल मेंटेन नहीं होता तो फिर हम उसको पीडी पे डाल देते हैं पेशेंट को. So we pass a peritoneal dialysis catheter and that allows us to do a bit of UF in that patient. उसकी ज़ाहिर अपने issues हैं because उनको pericatheter leaks बहुत ज़्यादा होते हैं, they're overloaded, उनकी जो it takes 24 hours के लिए आपको 2 weeks के लिए हमें catheter को without use रखना पड़ता है. और acute PD के लिए भी ये ज़रूरी है कि हम लोग जो dwells हैं वो short dwells करें और low volume dwells करें patient को supine लिटा के. लेकिन जाहिर है इतनी लो EF के ऊपर ओवरलोडेड पेशेंट सीधा लेटता ही नहीं है, तो पीडी ऑप्शन उधर से बाहर निकल जाती है.
Okay.
I think
Okay.
Ali कुछ कहना चाह रहे हैं. I think पहले वो बोले
हाँ.
फिर मैं I will respond.
Thank you. Cardiologist के हवाले से fortunately these cases are not so common. There are few of them. But in one experience, one of the cardiologists came and did a bedside echo and found some significant pericardial effusion. And once we drained it, everything got better. So I think cardiologist, जैसे आहद ने बताया, cannot do much, but हमारे बच्चों के लिए स्पेसिफिकली एक बड़ी मशहूर कार्डियोलॉजिस्ट हैं डॉक्टर नजमा पटेल, और इस तरह के कार्डियोरीनल के बच्चे जो हैं हम वी सेंड देम टू हर एंड शी पुट्स देम ऑन डोब्यूटामीन इन्फ्यूजन्स बिकॉज वो कार्डियोलॉजी का सेटअप है उनका बहुत अच्छा सा, और वहाँ पर वो फिर स्लो अल्ट्राफिल्ट्रेशन करते हैं और after a few days, like 5-7 days of daily dialysis, things improve.
Yeah, you're right. But we're talking about long-term problems. I mean, these are patients who are in dialysis unit. I mean, short-term, you're right. That could be issue. But long-term, only option you have, basically, cardiologist has practically no role to play, even here in America also. Okay, and the one reason is that most of these studies done in patient on any cardiac device or cardiac trial, they exclude the patient on dialysis. Okay, so basically you are, as a nephrologist, you have more knowledge what to do cardiology wise in a patient on dialysis as compared to cardiologists. So you need to guide them what to do, rather than you looking for them to tell you what to do. So, but option are limited. I think if patient agrees, then patient has available circumstances, more frequent dialysis is one way to go. And other than that, look at the medication, take out the medication which can cause low blood pressure. I don't think you have many options. So let me go over some questions are asking. Maybe we can talk to about those questions, which are sent to us in chat. I think we need to keep an eye on that. So let me go over first question. If a setting where you do have CRRT, why not PD? So where you do not have CRRT, why not PD? Yeah, again, PD, I don't know whether in Pakistan PD is available, acute PD or not. So that's again an acute situation. PD, if can be managed, that's not a bad options. But again, your ultrafiltration rate is very, limited many times, and it's not very easy to take fluid off with a PD also. In some cases, very slow ultrafiltration over 6 hours. So we spoke about that. We do daily dialysis along with dobutamine infusions. That's good options. And what is the normal blood pressure in setting of low EF? If patient is not dizzy and having the cerebral perfusion preserved, but having systolic blood pressure like 85 to 80, so would you like that as a physiological for time? And that's an important question, actually. So a patient who has
question, I think we should discuss about this.
Yes. So this is a good question. So Umar, I mean, why don't you start with some your thought about that?
So many of my patients who have like low EF 10-15%, and their blood pressure is usually in this 85, 80, 90s range. There are some good days when they have their blood pressure in low hundreds, and then they think it's the blood pressure is very high. So it's okay for them to have blood pressure in 80s and 90s, and you just take that 3-4 kilos, whatever they have gained during that treatment. यही जब मरीज हॉस्पिटल में जाते हैं तो जैसे ही हॉस्पिटल में वो देखते हैं कि जी इनका ब्लड प्रेशर 80 है, तो इंस्टेड ऑफ टेकिंग द फ्लूइड ऑफ, वो उनको एल्ब्यूमिन का वो लगा देते हैं, सेलिन का, वो ईआर में तो उनको सेलिन पहले मिल जाता है, एंड दैट एक्चुअली वर्सन्स देम. सो मेरे पास ऐसे जो पेशेंट हैं, मैं आई ऑलवेज एजुकेट देम कि अगर आप गलती से किसी भी हॉस्पिटल ईआर में चले जाएं तो आप उनको बताएं कि भाई ठीक है, तुमने अगर देने भी हैं फ्लूइड्स तो जस्ट बी लाइक केयरफुल, पहली बात. दूसरी बात, टेम्परेचर की बात की, एक्चुअली दैट ट्रिक वर्क्स इफ अ पेशेंट कैन टॉलरेट. कभी कभी टेम्परेचर लोअर करने से 1/2 डिग्री 1 डिग्री वो पेशेंट को थोड़े से वो वेजर कंस्ट्रिक्शन में चले जाते हैं, एक्चुअली दे डू टॉलरेट. सम ऑफ देम, नॉट एवरीबॉडी, क्योंकि उनके क्रैम्पिंग बहुत ज्यादा बढ़ जाती है. तीसरा जो ट्रिक जो सबसे ज्यादा काम करता है, और ये दिस इज ऑल बेस्ड ऑन टिप्स एंड ट्रिक्स, यू हैव टू कन्विंस द पेशेंट कि यू ऐड दैट एक्स्ट्रा ट्रीटमेंट, और वो जो है ना 4th ट्रीटमेंट in that week. और कभी कभी इन पेशेंट्स में ये होता है कि they are okay for 3 treatments a week for some weeks, and then maybe once or twice a month they need that extra treatment. कुछ पेशेंट, ये सारी नेगोशिएशन जो है ना पेशेंट के साथ, जिस तरह से आप लोग करते हो ना उधर पाकिस्तान में, हमें भी सारी करनी पड़ती है. आई थिंक यू हैव टू, बिकॉज nobody wants to come for the 4th treatment, but then once they start the benefit कि भाई क्योंकि मैंने इस महीने वो 4th ट्रीटमेंट once or twice किया तो I don't have to go to hospital, तो वो that works. दूसरा ये है कि you have to look at their medication very very closely. You need to make sure that उनका जो cardiac failure के medication है, those are optimized. Sometimes those medication that actually control their heart failure, they may be a blood pressure medication, but that actually goes a very long way. Carvedilol or Sartan, ये सारी चीजें जो हैं वो they go a very long way. Actually, they give them sometimes out of the trouble. तो बाकी midodrine, so that becomes tricky because we have used it, because if the blood pressure is super low, then you have to use it. Otherwise, you know, a lot of people are worried for arrhythmias. I have used midodrine a lot, I think, in these patients, and it works out okay. They're not dying from arrhythmia or something. And I think I have many patients who have done well. The best thing which I can offer them is if I can convert them to home dialysis, either PD or home hemo. Both modalities work really, really well. I think the home hemo gives them the leverage to do 4th or 5th treatment at their leisure. And now they can, even if they gain weight or they have that problem, plus the home hemo machine I use, or we all use here, is kind of sled, it's soft and gentle, and that extra treatment actually helps. So plus PD, I have some patients who have very low EF. Luckily, I was able to get a PD catheter in them by talking to anesthesia and by convincing them that, you know, this patient is going to get benefit from it. And now those patients, so one, they are prone to ascites, and now I think the volume control actually became very easy for me. I think I lost one of those patients because he became septic. Not necessarily from the PD catheter or PD, but he had amputation done, you know, diabetes, heart failure. So his leg was the problem, and then he was hospitalized. But overall, I have a good experience using peritoneal dialysis in these patients. So there are some tips and tricks. You need to make sure their heart is okay, their diet is okay, and how to manage, you know, home hemo, PD. Those are your preferred options. Twice a week dialysis for those congestive heart failure absolutely will not work. I'll stop here. I'll take other people's comment.
Yeah, I totally agree that some patients, they have chronically low blood pressure and they live in 80s and low 80s, 85, 80. And some patients even lower than that, and they're totally asymptomatic for their own like baseline symptom, which is not great, but that's their baseline symptoms. And when they go to hospital, they see the blood pressure is 80 and they call rapid response. Yeah. And then everybody comes and give fluid and everything. So that is actually cause a lot of problem. So if those patients are living in a blood pressure, systolic blood pressure 85 or 80, so I think that is okay. We don't need to make any change in their medication just for that blood pressure. So going back to the actually kind of take home message, what I think we recently have many discussion about pulmonary hypertension in patients with chronic kidney disease and stage kidney disease. So basically the bottom line is that these patients who develop congestive heart failure, who develop pulmonary hypertension, their survival there depends on lowering their pulmonary hypertension or preventing for development of pulmonary hypertension. So if you have loved one or you have any patient, you definitely want him or her to survive longer. Make sure that patients stay dry. Even that might increase his GFR over time a bit quicker. Maybe end up in dialysis even quicker for maybe 6 months sooner than otherwise if you can. But survival would be much better on this patient who tend to be dry rather than a bit overweight, volume overloaded. And also diuretics has to be managed properly. I know that the Lasix, how do you guys give a Lasix, once a day or twice a day, chronically?
I mean that depends, but more often we actually see 3 times a day. So every 8 hours, usually a patient is getting Lasix. If he's passing quite a bit of urine, there is a general tendency not to give it in the evenings, so just so that the patient is able to sleep well without getting to the bathroom every hour.
Yeah, that's the thing. You have to see the patient's living standard. Also, you don't want to stay home as like a hospital. You're right. Yeah. So the only sometimes we see the mistake of giving patient once a day furosemide, which is actually a short-acting medication. So if you're giving 2 times a day or 3 times a day, that's even better. Or you have to adjust the time. I mean, morning dose, then dose in the afternoon. That is okay. If patient don't want to take at evening, that's fine. But giving once a day probably would not work. But again, the emphasis is on make sure that patient doesn't go to chronically volume overloaded, that increase their pulmonary hypertension. You must have seen that patient, some patient on dialysis or patient CKD stage 3 or 4. Do you do BNP level over there? I mean, do you check for patient congestive heart failure patients?
Yeah, you see, well, some centers definitely do it, especially in the acute settings when some patient comes in short of breath. So the cardiologists are at our center always want to send off BNP. I'm not sure if every center believes in it, but our center does send a lot of BNP, especially the cardiologists do.
So you have seen that patient sometime, patient with the CKD stage 3, 4, or some dialysis patient. They come sometime, they're very like bone dry. And if you check their BNP is 5,000, okay? So that doesn't mean that they are volume overloaded, but that means that patient has pulmonary hypertension or chronically they have been subject to be volume overloaded and and that's a bad prognostic sign. So you don't want patient to be chronically in volume overload condition because that would definitely increase their mortality or bad outcome. Keep it dry.
It's very interesting that you bring that up, because I think about just 4 days ago we saw this patient who wasn't volume overloaded at all and had a BNP which was very high, and we couldn't figure out क्या problem है, 5,000 से ऊपर ही था उसका BNP भी. But in terms of maybe we're getting off track उसके topic के ऊपर से, but would you we would definitely work that patient up for pulmonary hypertension looking for a secondary cause, but in the US are you guys using sildenafil still या bosentan वगैरह क्या use कर रहे हैं इस चीज के लिए?
I mean, we use it, but again, we don't, as a nephrologist, we don't use it. Basically, I mean, there's actually pulmonary hypertension, a separate topic. There's a different, type of, there are 5 types of pulmonary hypertension. Basically, जो हम लोग deal करते हैं, that is basically type 2, which is basically because of congestive heart failure. In that particular patient which we deal, there's no role of that vasodilators, basically. So we should not be using that. That's basically is primary pulmonary hypertension. That's you have vasodilator or endothelin receptor blocker. That is their role. But patient who has pulmonary hypertension because of volume overload, there's no role for that. So, any other question? Let me see if anybody has any. So the basically take-home message that we try to be a little bit more aggressive as for the patient with the Cardiorenal Syndrome, diuresing those patients, because that will, and if that at the expense of slightly increase the urine creatinine, that is okay. That for these medication called ACE inhibitor or these medication Entresto, their effect is gone when you cause the hypotension, you can cause more damage than benefit because hypotension. So be very careful about not causing that hypotension because of these medication. So it's better to take them off if patient is getting hypotensive because of this medication Entresto. So that's very important to know because their renal perfusion is very, very, very delicate situation. Slightly low blood pressure, renal perfusion decreases, and then you can cause renal failure that indirectly or directly affect the heart also. So the benefit you will lose if blood pressure goes down. Okay, any other question anybody has? Okay, if not, then we should wrap it up. Okay.
I think Dr. Mateen कोई सवाल पूछना चाहते हैं from the Northern Lights. ये आपका नॉर्वे में या किधर है?
सर मुझे पता नहीं कैमरे का कोई ऐसा इशू हुआ है, वो लगता है ऐसे ही है जैसे मैं स्कैंडिनेवियन कंट्री में हूँ।
मुझे लग रहा है अलास्का में।
नॉर्दर्न जो लाइट्स हैं बड़ी खूबसूरत तरीके से दिखाई हैं हमें।
अलास्का में।
चलिए मैंने कहा सर जरा लाइट टच जो है ना ये भी
नहीं बड़ा जरूरी है।
Dr. Wes, any comments about the prevention in the cardiorenal syndrome? Main points for that?
Sorry, yeah.
For preventive measures for cardiac. Any, in the pathophysiology, you mentioned that ACE, ARBs will aggravate that of the cardiorenal syndrome. And in the treatment, you mentioned that in all aspects, you will, whatever the pathophysiology, you will give the ACE or ARBs.
Okay.
And in Pakistan, when the cardiology people called us for that of the rising serum creatinine, and we at one practice we stopped that of the diuretic, we stopped that of the ACE or ARBs with the serum creatinine rising of some 30% or 40%. So
I mean, again, if in a hospital situation, when you call because patient has congestive heart failure, patient has edema, and patient's urine creatinine is rising, and if patient is on ACE inhibitor ARB, I mean, follow please, this is not like a, give me your, maybe your opinion is different because that what we do, we stop ACE inhibitor ARBs if patient's urine creatinine is suddenly rising, okay, in that acute situation. So the main thing that these are good medication, ACE inhibitor ARBs for chronic maintenance of cardiorenal syndrome, not acute situation. Okay. So acute situation, you have to take care of the volume overload, diuretics, and keep the ACE inhibitor ARBs. But if you urine creatinine rise, which most likely will rise, and actually ACE inhibitor ARBs will potentiate the worsening of renal function temporarily at least, so it's better to hold them. But please make sure that when patients urine creatinine stabilize, before patient leave home, you should put that back on that. The other common one thing, Ahad, I know some people want to leave, that's okay. Any question about what do you call contrast nephropathy? You all want to talk about that? Any question about that? Contrast induced nephropathy? So Farooq, what you do, Umar, what you do in this situation in your and patient urine creatinine is rising and congestive heart failure, patient is on ACE inhibitor or ARBs?
Yeah, I think you are absolutely right. I think whenever they are in some sort of a steady state or in outpatient or in chronic state, I think in those situations those medications help. But whenever they are in the hospital in the acute decomposition or acute worsening, and they say they are not on dialysis, I think you have to give them a break. Otherwise, kidneys get into trouble. But once they are out of the woods, it's okay to put them back on those medication, because I think a lot of time, when they get discharged from the medicine, like non-cardiac services, they are less likely to go back on ACE inhibitor. When they get discharged from the cardiac services, they are most likely or more likely to be back on their ACE inhibitor. And it's really when in the middle of the acute phase, you have to give them a break. But once they are over, we need to put them back, because that's going to help with the heart.
So Ahad is still here or he left?
I
Okay.
think he left. I
Okay,
think
he want to talk about something, contrast nephropathy. So anybody had any question regarding contrast?
Sir, I just wanted to share a small scenario that I faced a couple of weeks back with a female patient who had acute coronary syndrome, actually. And her baseline creatinine had been 1.7, 1.8, and she was on ACE inhibitors and ARBs, a diabetic, obviously being a Pakistani female, non-compliant to in everything like that. So what happened was that we had to withdraw the ACE inhibitors and ARBs because the creatinine had turned to 2 and then 3 and then 4 in like 2 days. And the cardiologists were so afraid to injure the kidneys that they refused to do an angioplasty or a PCI. And because the daughter was a doctor herself, so she actually had to give an on bed death during the procedure death consent, and that was when they went ahead with the PCI. And the day she had her PCI, even though they gave minimal amount of contrast that was required, second day the creatinine had started to come down. So it was the insult because of the heart, not the contrast, but they were so afraid of it that we literally had to press our foot down to please go ahead, save the heart. You cannot save the patient if you cannot save the heart. So this was one scenario that I had to face, and luckily the creatinine came down to 1.5 after the procedure because we hydrated her well and stuff like that. But as soon as that cardiac insult was gone, patient started stabilizing. It had to be. So the message was that the cardiologists need to be educated more that, I mean, a patient cannot live without a heart. They can live without a kidney, but they can't live without a heart, especially in Pakistan.
I mean, absolutely. That's so well, you said very well, because you have to educate to cardiologists also sometime. Uh, you have to guide them what to do on the patient who has some renal issues. Like this particular is a prime example of that. First of all, let me tell you that what we have, I don't know whether Umar you agree or not, but I think what we have learned over the last 10 years or so that the risk of contrast-induced nephropathy is overblown. Okay, it's not that much as we think. Okay, and majority of the patients they have acute. I mean, when they have contrast nephropathy, acute kidney injury happens, but majority of the patients go back to baseline in 2-3 weeks. Okay, so that happens. So again, you have to definitely have to you have to weigh the pros and cons of doing cardiac arrest. Like this patient is dying otherwise. I mean, so what's the big deal? I mean, like in worst case scenario, patient will end up in dialysis temporarily. Not if patient creatinine was 1.5, there's a very high chances that even with slight or more rise in creatinine, eventually 2-3 weeks from now, she will have back to baseline or slightly higher than baseline. But again, if you don't do cardiac arrest, patient goes off to heart attack, she could die from that. So there was no reason to hold back patient cardiac arrest on this patient. So absolutely, you have to weigh the pros and cons. And again, uh, the risk of contrast-induced nephropathy is a bit uh, too much. I mean, this is less compared to what we have been, emphasized over the last few years or so. Actually, there was some study came out last year that showed that there's no such thing as a contrast-induced nephropathy. The study showed that there's no such thing, but that was not accepted. Omar, any
Yes,
comment
I
on that?
think definitely, I would definitely like to comment on this issue because I think I'm sure the data and how it has moved in the last few years from the radiology literature. If you look at the radiology literature, they are, I'm sorry, so they are saying that the contrast nephropathy does not exist. They call it a hoax. Their data by looking at 100,000 patients clearly, when you do the statistical analysis and propensity matching score and all that, I think they have beaten the numbers enough to give them the answer statistically that contrast nephropathy does not exist. So they looked at 100,000 CT scans with contrast and 100,000 without contrast and said, no, there is a baseline risk of contrast, like acute renal failure, it's going to happen. So I clearly do not believe in their data at all, because all of us in this group, we see contrast nephropathy day in, day out. Okay. So this does exist. I don't want to downplay it. I don't want to overplay it. I think we have taken the scare of contrast nephropathy to the next level as well. So you have to look at the situation. if a patient with CKD baseline creatinine 2 comes to the hospital and then ER doctor because of the belly pain and they want to do a contrast to it like look at the belly pain, I always tell them that, oh, hold off, get a non-contrast CT scan first and see if you really need to give the contrast, then go for a second study. So I block a lot of unnecessary contrast. Now flip the situation which you described, and I'm sorry I don't have your name on it, Dr. Sabha, but you described the situation absolutely beautifully and wonderfully. When patient is having active coronary artery syndrome, so they are in acute situation, giving them contrast is more beneficial. Saving the heart will take precedent on saving the kidney. And we are all nephrologists. I know this statement, nobody likes to say this openly, but that's the reality. So many of my patients, whether elective cardiac procedure or the urgent cardiac procedure, I always allow this to happen. And actually I convince the patient, I sit down with them. We are doing a lot of cardiac consults before their CABG surgery. The creatinine is 2 or 3, and I think they need some contrast. So we allow this to happen. Our pre-transplant patients, so those who have CKD 4 and 5, now they are being listed for a kidney transplant and they have a living donor. So your timing of the surgery is kind of imminent. We send most of them, actually all of them, to get heart cath. Even if they need stent, I think we let them place the stent. And I have sent so many patients. I have had 0 patients with the creatinine of 4 and 5 when they went for pre-transplant evaluation and heart cath, that I had to do permanent dialysis. I may have to do like a temporary dialysis 2 or 3 sessions, and then we stopped dialysis and they recovered from it. So yes, patients may get a reversible degree of acute renal failure, which they may end up on dialysis, but usually they recover back. We should not expose them to the risk of dialysis dependent acute renal failure. And if we can avoid contrast, that's wonderful. But in situations, Dr. Sabha, as you described, we need to convince patients and their doctors, like, save the heart. You can save the kidney later. It's kind of limb versus life situation. You save the life first, the limb, sometimes at the risk. So I agree, it needs some education. Things which we can do is, I think you mentioned stopping their ACE inhibitor, stopping their diuretics, making sure that their volume status is optimized, giving them a little bit fluid before and after. There is a lot of data to suggest that. Isotonic fluids, I know there were some medication like were very popular, acetylcysteine and all that. It's an inert substance. If somebody wants to use it, I never stop them. But if somebody asks me, like, would you prescribe it? I don't think there is a huge benefit. But this medication that gives them a placebo effect, so patients are happy, cardiologists are happy. So sometimes I play with the psyche of the cardiologist and show them the NAGM paper and give them this drug, explaining patient that, hey, listen, there's nothing to lose, but there is this placebo effect. There's published data. What works is isotonic IV fluids more than the bicarb drip. So you do your end. I think sometimes you have to be the advocate for our patients and play a little bit game. I think you did the right thing. This patient really needed the heart cath and nothing bad happened. And even they were probably convinced that after fixing the heart, the creatinine actually improved by itself. So good job, strong work.
Okay, just a small comment on that. SSS line 16. We have not used it for the last 5 years, and actually, if somebody uses it, we make fun of that person that you don't know. I mean, you were which are you living in, and so because I told them cardiologist, it's a cardiologist data which showed that it does not work. It's a useless medication. You should not be giving that. And so in our hospital, I don't think anybody has given for the last 5 years or so.
Yeah, I agree. I think I gave my disclaimer that I will never prescribe it primarily. And I completely agree with you, Dr. Masood, but I think sometimes I have some cardiologists who this is fixated in their heart.
Yes, you're right.
So it's just like, this, they will never go away with this.
But you're right.
This thought, I explain it to patient.
Zero side
patients
effect.
are okay usually.
This medication has zero side effect, very safe, no effect other than if you give IV otherwise, but PO has absolute no known side effect. You are absolutely right. It's pretty safe. Yes.
So it's a psychological treatment. It's like an anti-anxiety drug, which we allow them to use. I think that there's a comment for, yes, so somebody else has also mentioned that actually use acetylcysteine for placebo effect for the cardiologist in this particular patient. Good job. I think at the end, it's like, it's okay. Common sense is usually not very common, but I think you use it very well.
I heard it tastes bad. I mean, it's bad. It's not very tasty.
Mm-hmm.
It smells bad and it tastes bad. I don't know.
Yeah, once I asked one of the cardiologists to actually taste and try this drug on himself. So because the debate was so heated, and I think this was a few years ago, maybe since my hair are getting gray, I'm kind of backing off on a lot of those arguments because those are useless arguments.
So actually there was a time when we used so much this drug that there was a time then if patient cannot take PO, this drug, we were giving, I gave like one time at least IV this medication, which is at time like maybe 15 years ago, it was like a peak of its use, and everybody saying that, oh, I can get this medication, you should be okay, you'll be fine, you don't have any cardiac kidney issues because you got this medication. But then, so
anybody else wants to comment on N-acetylcysteine? Because again, I think we are okay. We are out of there's some data. It's a data-free zone. So let's see if you have some personal experience. I think it's good for the group to know.
Yeah, just same thing at SIUT also. The radiologists would not get convinced otherwise unless we give that N-acetylcysteine. So even for our fistulograms or for angioplasties of fistulas, they would like us to give N-acetylcysteine, and regardless of what we show them the data, we have to give it, and we just don't mind giving it.
okay, so basically when they're doing a fistula, so no study shown that if you give less than 20 ml, you would have any sign of any contrast nephropathy. So they should not be. Again, you will convince that. Sometimes it's hard to convince radiologists. Yeah, if we just 20 ml or sometimes 10 ml, you go by with doing a fistulogram, there's absolutely no risk for contrast nephropathy. And the fluid, we have tried many, but again, the only one fluid which need to be given, that is normal saline. Bicarb has equally effective, but can cause some metabolic complications, and there's no advantage of giving bicarb. So normal saline should be given. Farooq, do you hold ACE inhibitor ARBs or you don't?
Yes, actually, one just on the day of the procedure, if I can. But if patient is up, like this is urgent, then and we did a meta-analysis from my group. Actually, did that, and we did not see any difference in that population, that whether you hold the ACE inhibitor or you don't hold the ACE inhibitor. I think again, I hold it on the day of the procedure because maybe for the psychological hand holding. And I'm sorry, I'm just telling you certain things which I just do for the sake of the sanity to prevail.
About metanephrine?
Which one? Metformin, you mean?
Sorry, metformin.
Yeah, I hold metformin. I think because there is a lot of unknown with the metformin and how it's gonna what if they go into kidney failure and the GFR is lower. I think in that, it's not like we have data, but it's just like there is so much unknown for the metformin.
Yeah, we hold, it depends on patient GFR. If patient GFR is less than 1.5, we don't hold metformin because the data shows that the risk of contrasting nephropathy, I mean, you have not only GFR, but as well other risk factors like diabetic or congestive heart failure or EF. But if none of those has, then we don't hold it. If patient has multiple risk factors for contrast nephropathy, you need to hold on metformin. Yes. But again, ACE inhibitor, ARBs, we don't hold it because again, as you said, the data does not support that. We used to do that, no question about that. Until 3-4 years ago, we used to hold it, but not anymore.
And any other comments? I think sometimes it's very good to hear the perspective.
Okay, if there's no other question left, I think we can wrap it up.
Thank you.
or call it a day or night. Okay, thank you everybody. Good night.
Thank you, Dr. Umar. Scene
Good
पसंद
night.
आया? Dr. Umar, scene पसंद आया पीछे?
Thank you for showing that.
Thank you.
Okay,
Thank you.
Assalamu alaikum.
Okay.